Hello, and welcome to today's webinar called Denied Due to Lack of Medical Necessity, Preventing and Responding to Insurance Denials for PANS and PANDAS Treatments, presented by Elizabeth Urias. My name is Susan Boaz. I am the Executive Director of the PANDAS Physician Network. We are a nonprofit organization with a vision that PANS and PANDAS will become easily diagnosed and treated with accessible therapies that will dramatically reduce suffering and lead to a cure for those patients. Today's webinar is going to include a recorded presentation followed by a live section. During the recorded presentation, Beth and the PPN staff will be available to answer your questions if you send them via the Q&A button at the bottom of the screen. After the presentation, we will shift to a live section to hear your questions that you may have to ask personally. The content shared with you today is not to be considered legal advice or medical advice. Information about obtaining CME credits will be sent after the webinar. We'd like to extend a special thank you to At Point of Care and Projects and Knowledge for making the accreditation of today's webinar possible. Okay, now we'd like to welcome our presenter, Elizabeth Urias. Elizabeth is a licensed marriage and family therapist and the president and founder of Clearly Clinical, a nationally approved podcast-based continuing education company for behavioral health professionals. Beth serves as a trainer, consultant, and works closely with clinical teams to improve their quality of care, documentation practices, and utilization review outcomes. In addition to being an adjunct graduate psychology professor at Pepperdine University, she's also a private practice therapist and a PANS parent herself. Beth, welcome. We're so glad you're here. I'll turn this over to you.
Hello, everybody, and my gratitude to PPN for having me here today. I am honored to be spending this time with you, and I sincerely hope that we can make this hour as beneficial for you as absolutely possible. With that, let's dive right on in. My name is Beth Urias, and I'm a licensed marriage and family therapist. What I am not is an attorney, and I'm also not a doctor. So today's presentation is not legal or medical advice. I'm the president and founder of Clearly Clinical, which is a podcast-based national continuing ed company for mental health professionals. I'm also a utilization review and clinical documentation trainer and consultant. I work with teams across the country on understanding utilization review requirements and how to best advocate for our patients, which is what we'll be talking about today. I'm also a private practice therapist. I'm adjunct faculty at Pepperdine University in Malibu. And perhaps most importantly to today's conversation, I am also a PANS parent. So when I speak, I speak from not only my knowledge of utilization review, but also my reality as a PANS parent. And I know all of you are all too familiar with this illness. And I thank you for your work and your advocacy and just attending today's presentation and having this conversation. So today's presentation, we're going to spend just a little bit of time talking about medical necessity. It's something you're all very familiar with, but really how do we get it into clinical documentation and make sure that that documentation is then used for determinations for our authorization requests and for potentially appeals. We're going to be talking a bit about utilization review related laws. When I started out, before I was in behavioral health, I actually used to work in medical, and utilization review was this whole process behind the curtain that I really wasn't familiar with, and I didn't understand how the game was played, so to speak. So my goal today is to help give you some more information about how the game is played with insurance companies and how to best advocate. And we're going to be talking also about the systems that are coming into play with utilization review and utilization management, because I think we can't really navigate the system as well as possible if we don't even understand the system. And then we're also going to be talking about advocacy strategies. We will, for those who are watching this live, we will have the chat window open so you can ask questions that way. And also you are welcome at the end to ask questions through the Q&A and perhaps through chat, and we'll be answering those as well. So the presentation part of today's presentation will be about 40 to 50 minutes, and then we'll have Q&A at the end. For me, the way I see it, this is deeply personal. We live in an environment where we have a really flawed care system. Utilization review, in a lot of ways, is the only way that providers can advocate for care for their patients. And speaking as a PANS parent that has been through authorization and denial processes too many times. I'd have to think about how many times. For me, this is really personal, and connecting with other families, hearing from PANS physicians that they were just getting denial after denial. And then I hear these horror stories about families that have taken out second mortgages on their home in order to be able to afford IVIG. And my goal in this discussion today is simply to give you as much information as I can to help ready you and your teams to best advocate for coverage with insurance companies for these treatments. Really, what we're talking about today is in the best interest of patients and families. And what's difficult is you went to med school or nursing school not to do this. you went to your educational programs and did your residencies in order to treat your patients, not to advocate with insurance companies in order to be able to treat your patients. So I want to first acknowledge you're automatically working with a high risk, high need population. And then you have this additional administrative element that's coming up. So again, my job here is to try to facilitate as much understanding as I can. And the only way that I know how to make this stick is with a little bit of humor so that nobody falls asleep, because most of us are not really excited to talk about clinical documentation utilization review. So thank you again for attending. But we are operating in a flawed system. It's generally my perspective with insurance companies that we catch a lot more a lot more flies with honey than we do with any other substance for that matter. But so I want to empower you to understand the process and also help you advocate as efficiently as you can, because your time is really well spent with patients and with families, not in this part. So I'm going to try to make this as brief and as succinct as I can. So to start off with learning the system, as we're talking about third-party payers for medical care, I want you to first start out with a framework of being mindful of the difference. Your job as a provider is to treat and heal your patient. The insurance company's goal in utilization review and proceedings is to monitor the appropriateness of care and to reduce costs. We live in an environment where there have been some bad apples that have committed pretty egregious fraud. And because of that, utilization review exists, and wanting, I think, ultimately to do best by the patient, but it's hard to not get discouraged and frustrated with this process, because something can seem clear as day to you and be completely justified medically, but then you get a denial handed down by whatever insurance company, and goodness knows how that affects a patient and a family. Really, your notes are setting the tone for this case and whether or not this care is actually ultimately authorized. So when considering writing your notes, we'll talk about kind of some perspectives with this, but I think it's critical to think about why you're recommending a particular treatment or even a particular diagnosis. And we'll talk a little bit about this today, but really viewing your clinical documentation as the backbone to an effective authorization request. And then if it's denied, going through the internal and external appeal proceedings, it's your documentation that's really going to set the tone for the entire case and ultimately probably determine whether or not that treatment is authorized. A brief review of medical necessity. So before we move into that, how many of you have made this face when talking with an insurance reviewer? Or my personal favorite is me holding the phone with my forehead down on the desk because I'm just so frustrated and discouraged. If you have been there, you're not the only one. And we're going to talk about how to navigate the system without completely losing your cool, because sometimes it does feel like the odds can be really stacked against you, depending on what reviewer you're speaking with, what insurance company, even what treatment you're advocating for. So you're not the only one that's made that face. Let's talk through it a bit. This is one of my favorite definitions of medical necessity because I'm that kind of person who has favorite definitions of medical necessity. This is from a book called Treatment Planning for Person-Centered Care by Adams and Greeter. Simply stated, the demonstration of medical necessity requires that there is a legitimate clinical need and that services provided are an appropriate response. Two elements: legitimate clinical need and that the services provided are an appropriate clinical response. Why I bring this up is because sometimes we may advocate for a particular treatment and then not appropriately document whether or not that treatment was effective. So that second element is what's going to really form the backbone for future treatment. So we say, okay, we tried antibiotics in the treatment of PANS for this patient. And now we need to up the ante because the antibiotics produced some effect, but not enough to really say that this person is in remission. So now we're going to proceed with an authorization request for intravenous immunoglobulin, for example. So keeping in mind that medical necessity has two components, it's the legitimate clinical need, and then also that services provided are an appropriate response, and making sure that we're documenting both of those elements. So why did we up the ante from antibiotics, anti-inflammatories into, for example, immunomodulatory care? These are kind of elements to keep in mind. And when I'm reviewing and auditing either medical or behavioral health charts, what I'm looking for is really the why. We're relatively good at getting the other 4 W's, the who, what, where, and when, but sometimes it's the why that we're missing. So why did we diagnose PANS, PANDAS, autoimmune encephalitis to begin with? And then why are we recommending this particular care right now? So whether that's an initial request for intravenous immunoglobulin or it's a subsequent request for refill on rituximab and another infusion after there's already been, make sure that we're always documenting the why in your clinical chart. And one thing I want to note about medical necessity, there really is not a firm federal definition of medical necessity. And in the absence of that, that left it really up to states to define medical necessity, which we'll get to. And some level, really important for today's conversation, it also left it up to insurance companies to define medical necessity. So here's just one example, but there are lots and lots of examples of medical necessity criteria. The Affordable Care Act made it required that insurance companies release their medical necessity criteria publicly. So if you find yourself often working, for example, with Anthem Blue Cross, then you should call Anthem Blue Cross and get a copy of their medical necessity criteria specifically for the treatments that you're looking for. And they may even have them for the actual conditions, but you really want to have those because they're basically a dialect that you want to use with the insurance company when you're advocating for whatever particular patient or treatment, for them to understand what you're requesting because you're putting it in their language. So I really recommend getting a copy of those medical necessity criteria, reviewing them when you have the opportunity, certainly reviewing them before you have a peer-to-peer call with an insurance company, because again, it is the dialect that they're going to be speaking and evaluating your request with. And I want to really break down a denial process as concretely as I can. In making today's presentation, I made the slides a little bit text heavy. And the reason is so that you can have copies of these slides and easily refer to them in the future. So we will have those available to you. And we have a handout that breaks down not unfortunately all of the medical necessity laws, but some of the most critical ones in the larger states where we see more issues coming up, as well as some helpful studies that you can use when advocating for certain treatments for your patients. So to transition here into breaking down denials, this is an excerpt from an actual letter about rituximab, in this case, specifically Ruxience. And I want to read it and then break it down with you. So this is the excerpt from the actual letter. Your request for Ruxience for the inflammation in your brain, autoimmune encephalitis, cannot be approved for payment. The reason is that Ruxience is not medically necessary for you. There are no Food and Drug Administration approved or off-label uses for Ruxience for your condition. We cannot approve a drug for use that is not approved by the FDA. This decision is based upon the insurance company policy rituximab Ruxience. Your appeal is also reviewed by an expert pediatric rheumatologist who agrees with this denial, stating that Ruxience is considered not medically necessary for the treatment of your child's condition, in this case, pediatric autoimmune neuropsychiatric disorders associated with strep. Member's appeal was reviewed by an independent pediatric rheumatologist who agrees with this denial. So I want to point out from this letter, you've probably received many letters relating to denials, which is probably why you're here. If you had received so many that were approvals, then you may not need this conversation. There was a time when these letters were essentially what we call robo letters. They were robo written. They were automatically generated by the insurance company. probably about 10 years. Now there tends to be more focus on actually creating a letter that is custom for each patient, each review, but they do have frequent reasons for the denial that might come up. And I want to point out this letter because it actually talks about a couple. So number one, they say that there's no FDA approved use or off-label use of Ruxience for this condition, and that they cannot approve a drug that is not approved by the FDA. And they also say simply that it's not considered medically necessary. So let's break that down. California Welfare and Institutions Code, and I'm pulling from California because that's where I am, but I will talk a little bit more about the laws as this presentation progresses. But just to give you an example, so California Welfare and Institutions Code very clearly defines medical necessity, and they say that a service is medically necessary when it is reasonable and necessary to protect life, to prevent significant illness or significant disability, or to alleviate severe pain. Every state in the union has some version of this law that defines medical necessity. Again, in the handout, we have some of the most populous states where this is coming up. But for most of you, if you're not in one of those states, if you just Google medical necessity law and your state, you could probably come up with something. And I also recommend speaking with your professional association because they may have that easily accessible and readily available to you. But it's important that you know your state's definition of medical necessity. So another point I want to make about California specifically, we have watchdog organizations, which we'll talk more about later. And these watchdog organizations are designed to make sure that the insurance companies are following the rules, basically, that they're not taking too long for authorization requests, that they are authorizing services that are medically necessary per that particular state. And it ultimately, most of the time is reviewed by a doctor or multiple MDs at an external watchdog agency that's run by the state in order to basically regulate the insurance companies. I bring up this law also in California because it's one of the most illustrative that I've seen. So this law from Health and Safety Code in California is looking at an independent medical review application. So what an IMR is the appeal that we write externally once we've gone through all of the internal appeals. And so we go to Department of Managed Healthcare, assuming they're who manages the policy in California, and we say, gosh, this treatment request for plasmapheresis was denied. We believe it's medically necessary and we're seeking authorization. Can you please overturn this denial? When they're reviewing it in California, they're looking specifically at 5 elements. So number one, is there peer-reviewed scientific or medical evidence regarding the effectiveness of the disputed service? Number 2, is it a nationally recognized professional standard? Number 3, expert opinion. And number 4, generally accepted standards of medical practice. And number 5, that the treatments are likely to provide a benefit to a patient for conditions for which other treatments are not clinically efficacious. So why I bring up this law, again, knowing that not all of you are in California, most states have some version of this law that will say, basically, here are the criteria that we're using to assess whether or not a service is medically necessary as the regulatory. So that's unrelated to whether or not the insurance company says it's medically necessary. It's basically a third party that doesn't have a stake with the insurance company and can say, yes, it was medically necessary, or no, it's not, and we're going to uphold the denial. This law, why I appreciate in California, is because it's so clear in saying, here's all the stuff we're going to look at. We're going to look at whether or not there's peer-reviewed scientific or medical evidence, if it's nationally recognized professional standard, if there's expert opinion, what are the standards, and if other treatments haven't been effective. Why this is relevant for you to know this law is because I want you to start thinking about this law or your state's version of this law as the groundwork for advocating with the insurance company. So it's not just about what we're presenting relating to this patient, it's also about the scientific and medical evidence. It's also about presenting professional standards. It's also about presenting expert opinion so that we're forming this case as if it's going to go to a denial and appeal anyway from the get-go. So we come out of the gate really strong. So it's really about strategy. Going back to that letter, I want to say this denial for Ruxience, there is no requirement in the state of California that a service or treatment be approved by the FDA in order to be considered medically necessary. So for those of you who have had services denied before because they say, well, it's not approved by the FDA for the treatment of PANS, PANDAS, autoimmune encephalitis, therefore we're not going to cover it. Something really interesting happened. And for those of you who are in California, just know specifically all you actually need is 2 studies that report two peer-reviewed studies that report the efficacy of the requested treatment. As long as that exists, it doesn't matter if there's an FDA approval. So again, for those of you in California, you just need to show 2 studies that say, here's why this treatment is appropriate and medically sound, and it's irrelevant whether or not there's an FDA approval. But moreover, for those of you not in California, back in February of 2022, there was a case in the US Court of Appeals in the 11th Circuit that was reviewing non-FDA approved off-label use of a medication. And they sided with the patient, and why this is relevant. And you'll have a copy of these laws in the handouts, just so you know. Why this is relevant is because it basically, from a case law standpoint, and again, not an attorney, from a case law standpoint, took away the insurance company's ability to deny a service because it's not FDA approved for that particular treatment. How this is going to boil down in the courts has yet to be seen, but this happened on a federal level. So it really does affect all of us. So if you're getting those robo letters or any letters from insurance companies about denials that say it's not approved by the FDA, you need to have a copy of this law and provide it to the insurance company and say, show me where it says that it has to be approved by the FDA for this condition in order for it to be medically necessary. So how to use all of this information? You quote it. Thank you, Drew Barrymore. I want you to quote it in your letters to the insurance company. I want you to even potentially quote it in your notes or in a case note. I want you to quote it when you're on the phone with a peer reviewer with the insurance company. So I want you to know your state's medical necessity laws. Again, we're going to be providing the heaviest hitting ones to you. And for those of you who don't have them on that list, do some Googling, ask your professional association. You might have an attorney friend that can help you find them. Also, I want you to have these laws handy when you're doing a peer-to-peer and when you're writing appeals. I want them quoted directly. So if there are laws out there like the Department of Managed Healthcare law that we were just reviewing, where it says a service is medically necessary when, and it's breaking down those 5 different components, that's what you need to be quoting. So when an insurance company says, well, I don't believe that this request for intravenous immunoglobulin for this patient is medically necessary, you can say, well, that's interesting because I'm looking at California law, and per California law, per Georgia law, whatever it is, here's what they describe as medically necessary. So what do we do about that discrepancy? And as we continue this presentation, I want to give you some examples of state laws relating to UR because I think they're really helpful. Again, a lot of professionals, I know when I started doing UR, I didn't even know that these laws existed. It made sense that they did, but I was busy working with patients and working on authorization, so I wasn't really concerned about the legal side of things. So I want to share some other laws that I think are really relevant for you. I'm pulling from the California Corporate Practice of Medicine Doctrine. And long story short, the Corporate Practice of Medicine Doctrine basically makes it unlawful for unlicensed persons to practice medicine and make clinical decisions. I've worked with a number of attorneys in both medical and behavioral health care during my time. And this law is really interesting because I've heard a number of attorneys say that it's relevant because insurance companies inherently are not, they're not medical professionals. Blue Shield is not a medical professional. Cigna is not a medical professional. And it can sometimes appear that there's a violation of the Corporate Practice of Medicine Doctrine because you have these corporations, insurance companies saying, well, you can't do XYZ, it's not medically necessary. And the legal argument can be made that by that assertion, the insurance company may actually be violating the Corporate Practice of Medicine Doctrine because they are therefore then making a treatment decision about a patient who they're not treating and they're not responsible for. About 30 states have their own version of the Corporate Practice of Medicine Doctrine. And we have a link to an article that covers, I think, all 30 in it. And again, these things are subject to change. So as we're recording this, it's in March of 2023, so things can be updated. But I think it's really important for you to know specifically if your state has a corporate practice of medicine doctrine law. And keep in mind that that's something that you can use to advocate with insurance companies by saying, whoa, whoa, whoa. So you're saying I can't do this treatment, you won't authorize it, and it's cost prohibitive. And by doing that, you may be violating the corporate practice of medicine doctrine. And it's been my experience that often when we're having a peer-to-peer or you're talking to a case manager, they're looking at the clinical details, not so much at the administrative piece. But it's been my experience that when you're on the phone with somebody and you say, well, actually, according to this law, yada, 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 here's the thing, and you bring up that discrepancy, it's been my experience that they go, whoa, we're talking to somebody who really knows basically what the laws are in our state, and we can't pull the wool over their eyes, like that letter that I was sharing earlier about rituximab, where they say, and think about this. So here's a letter coming from an insurance company that says, sorry, it's not FDA approved for this condition, it's not medically necessary. How many patients, families, and providers take that at face value? And to share about that particular case, that one did go to the watchdog agency, and they investigated it and found that the provider had provided sufficient evidence for that service being medically necessary, and had basically checked all the boxes in the state of California to say that it was medically necessary for that child to have rituximab. And the insurance company was ultimately fined because of their negligence in denying the authorization request. So when we're thinking about the framework of these laws, they're important to understand, because just because an insurance company says that something isn't medically necessary doesn't mean that that denial is even legally compliant. And like, I want to let that sink in for a minute, but just because an insurance company has said that it's not medically necessary doesn't mean that it's not actually in violation of a law in your state designed to protect patients. So moving out of California, here's Florida's version. This is not the corporate practice of medicine doctrine. This is the medical necessity definition. So in Florida, a condition or a treatment for a condition is medically necessary when it will prevent, diagnose, correct, cure, alleviate, or preclude deterioration of a condition that threatens life, causes pain or suffering, and results in illness or infirmity. Why I bring up this law, notice that there's even a discussion of preclude deterioration. That's really helpful with PANDAS and autoimmune encephalitis, because sometimes we have children or adults who are functioning at a different baseline because of long-standing illness or severity of illness. And we may not even necessarily be trying to bring things down in terms of their symptoms. We may be simply trying to prevent a deterioration of those symptoms. And why it's important for you to know this law if you're in Florida is so that you can say, well, here is this law in Florida that's saying that actually just the research that could show, for example, that IVIG is medically necessary because it can shorten the length of flares, that would lend itself to preclude deterioration, for example, or that it could alleviate or correct the condition. So when you're writing an appeal or talking to the insurance company and you're in Florida, I want you to have a copy of this letter, like posted on the side of your monitor. I want you to have a copy of this law and be able to quote it directly to the insurance company and say, well, I hear what you're saying about IVIG maybe not being necessary for this patient. However, I want to point out this, and also these few research points that say otherwise. And this is also my patient, and I want to make sure that we're not violating a corporate practice of medicine doctrine, because if I'm understanding correctly, you're saying you won't authorize this treatment, but you're not the one who's individually responsible for the patient. I am. My treatment program is, not you, XYZ insurance company. Moving out of Florida and going to New York, another medical necessity definition here. So service medically necessary if they prevent, diagnose, correct, or cure conditions in the person that cause acute suffering, endanger life, result in illness or infirmity, interfere with such person's capacity for normal activity, or threaten some significant handicap. The reason I included this definition is because of how thorough it is. So it's not just a treatment that could prevent or diagnose, correct, or cure conditions, but it actually is addressing whether or not that condition interferes with a person's capacity for normal activity and it threatens some kind of significant handicap. As I've said, not a doctor, but I have reviewed so many medical journals about PANS, PANDAS, autoimmune encephalitis, and the treatments and the different studies that have been done. And we know from the research that basically the longer somebody's PANS, PANDAS, autoimmune encephalitis goes on, the higher risk there is for brain damage. Use this law and say that this threatens a significant handicap. And if the person isn't able to go to school because they have such severe separation anxiety and limited distress tolerance skills, then it does affect the person's capacity for normal activity. So again, I want you to have a copy of this law. So when you're talking with the insurance company, you can refer directly to it and say, okay, look, so I hear what you're saying, this isn't medically necessary, but here's what the law is in New York. Can we talk about this discrepancy? And just as another example, here's Texas's version, which says that services are necessary to correct or ameliorate a defect or physical or mental illness or condition. Not as thorough as New York. And why I bring this up is that sometimes laws like New York and California give us a lot to work with, sometimes not as much in Texas. But nonetheless, it's important that you know what your state's laws are, because the insurance company almost certainly knows what they are, and you want to know what they are as well in order to be able to advocate effectively. So the bottom line, there are discrepancies between what the insurance companies are considering medically necessary treatment and how the states actually view it from a legal perspective. So in other words, the insurance company's definition of medical necessity is not the law of the land. It's actually lower than the state definition of medical necessity. And a quick review about insurance systems. I call them scripts. When you're on the phone with the insurance company and they say, okay, doctor, can you please give me the 3 most disruptive symptoms to this child's quality of life? And you have 12 on the chart in front of you on the computer screen. The insurance company may basically try to make it seem like you can only provide them with 3. You have the right to provide the entire record, and they're required to read it. Let me take a sip of tea. But why I bring this up is sometimes it can seem like they don't want that additional clinical detail. They're required to collect whatever you provide to them. So if they say, oh, no, it's okay, I only need 3 symptoms, then you say, actually, it's not okay. I understand that you're focused on brevity, but I want to provide you all of the symptoms that are affecting this one's quality of life. So don't fall prey to the script. Insurance companies have them in order to try and keep things as succinct as they can. But it can also mean that on their end, they're not capturing all the medical necessity information because they're selectively leaving some out. So make sure to combat that. In your denial letter from the insurance company, if unfortunately the treatment is denied, it's really important that you save that letter. It's really important that if you're on the phone with a reviewer and they say, you know, I'm just going to tell you right now, doctor, we're denying your request for plasmapheresis. It's really important that you say, can you please fax me that denial letter as soon as possible, or email it or whatever else, and ask the patient for it, because the last page of that denial letter, it's required that it tells you which watchdog agency manages that particular policy. So if you needed to go through an internal review process and ended up at the external review process, you'd have to know specifically which agency. So in California, for example, there are actually 3 watchdog agencies. We have the Department of Managed Healthcare and Department of Insurance, and there's a 3rd that's for a very unique kind of plan that isn't very popular, well, very common, I should say. It's important in that letter that we know exactly which appealing agency this goes to. You can also find this information out by talking with the client's or patient's insurance company and asking them directly who's the regulatory body overseeing this policy, so that you can know in advance, okay, and document that in the chart. Okay, if this is denied, then we're going to go to an appeal with XYZ body. So an interesting note, these are metrics that I've learned over time, and also that I've discussed with multiple attorneys who work in healthcare law. About 95% or higher of denials are upheld in subsequent review. So when you ask for IVIG and the insurance company says no, and then it says, well, you can appeal it again, just know that the likelihood that they're going to uphold that appeal is very, very high. That doesn't mean that the service isn't medically necessary or that the chart doesn't have adequate information. It just means that internally the probability of them overturning it is not in your favor. However, we need to go through that internal review process in order for it to get to the external review, which are the WAG agencies that are really advocating for patients and families. So in order for the appeal to go to a higher regulatory body, it must go through all levels of internal appeal. You can't skip steps. And also one thing I want to point out, reviewing nurses and doctors are not always specialized in the condition that they're reviewing. So it's okay for you to ask. There was a point in time where you would have a psychiatric hospitalization request that was being reviewed by a gynecologist. That is not supposed to be happening anymore, but that doesn't mean that it doesn't happen. That you have a pharmacist who's reviewing a treatment for a heart condition. Sometimes we want to illustrate bad faith on the part of the insurance company and say, well, look, they were speaking with a pediatric rheumatologist with 15 years experience and highly specialized in autoimmune encephalitis, and it was assigned to somebody who has never treated the condition. Not only do you point that out with the insurance company, but you make sure to document it. Please, please, please make sure to document it in the patient's chart, because if it goes to an external review, if the external reviewer can see that there was an act of bad faith by the insurance company, it makes it more likely for there to be a denial overturn. And obviously that's what we want, is for your patients to get the authorizations that they need. Another thing to consider is that you should always request expedited processing. The standard turnaround time for an appeal internally is 30 days. A lot of these people who have PANS, PANDAS, AE don't have 30 days just sitting there. We know how intense these symptoms can get. So in order to justify an expedited request, and you should always be requesting an expedited appeal and review, there must be a clear illustration in the chart of imminent risk without the requested treatment. This comes down to your notes. So don't just request the appeal, but always request it expedited and make sure that your notes illustrate how there's some kind of imminent risk without this treatment, so that it's processed within 48 to 72 hours. Going back to those watchdog organizations, like I said, every single state has some version of a WAG agency, if not multiple. It's critical that you get that last page of the letter to tell you exactly which one manages this policy and what the process is. Many of us will get that big denial letter that's 7 pages long, and we just see that front page. It says, like, we reviewed your case and the requested service has been denied. Don't throw the rest away. That's really where important information is. And a little bit of comfort for you in terms of this process of potentially doing an external review. In California, the Department of Managed Healthcare, just as an example, they overturn denials more than 60% of the time. So to let that sink in for a minute, that means that for more than half of the cases that end up on their desks, they're overturning them and siding with the patient, not with the insurance company. These external appeals are not a waste of your time. And I know that it may not be you who's literally doing these appeals, it may be your medical staff. But really, if the medical chart speaks for itself and medical necessity, that why is clearly illustrated, then it shouldn't take a lot of legwork to advocate with these third-party external watchdog agencies in order to get that denial overturned. And again, expedite it immediately and make sure that your chart backs up the expedite request so that we're capturing medical necessity. I want to also give you a very quick overview of how I do an external appeal. I have written more than I can count. My appeals, I've been fortunate to have been really well trained by some attorneys. I've actually never had one denied in the state of California. So every single time that a case has been denied internally with an insurance company, every single time that I've used this structure to file an appeal with the external watchdog agency, each time it's been overturned and the patient has been granted coverage for that service. I didn't know that I was going to have to do this repeatedly for my own child, but my odds still stuck. And every time that care was denied, I filed an appeal and it was ultimately overturned with that external watchdog agency. So again, this is in your handout, but here are the things that I include when I'm writing an external appeal. Number one, I want support letters from colleagues, from other professionals. So that could be someone who is consulted on the case. That could be an MD at another program. I've been known to reach out to the university-based programs and say, hey, could you provide a brief letter saying you've never treated this patient, but you do know that IVIG is a common course of action when the symptoms are this acute and severe? And they were kind enough to oblige. So support letters is very helpful because keep in mind the California law, at least here in California, expert opinion is one of the things that helps support medical necessity. So that expert opinion can either come from people who are actually treating the patient or other experts. I provide an overview of the symptoms in the history of the patient, as well as the treatments that they've tried and the result, and almost most importantly, the functional impairment that remains. So is it age appropriate social functioning? Is it risk of dying by suicide? What is it here that's at risk? And really honing in on that information succinctly in an appeal. Number 3 is published research. I literally quote studies in the letter to the payer or the watchdog agency. I will pull out the studies, quote them all, provide a reference sheet, and then most importantly, pull very clear illustrations from those studies describing how the service is medically necessary because it's been tested. And number 4, then I review any state or federal laws about medical necessity with an explanation about how the service satisfies medical necessity per the state definition. And then I'll use the payer's own medical necessity standards. So let's pretend the payer says we only pay for a certain service when XYZ factors are met. So for example, that you needed to have tried 3 other antibiotics and failed on those before we'll authorize this more expensive one. Quote those criteria and illustrate how the patient's case meets those criteria and break down using their own language, again, that dialect, and describe not only how it meets the state definition, but also how it specifically meets the payer's definition if it does. And I should note, there are lots of cases that are going on even as we speak in many states, because there are sometimes discrepancies between the insurance company definition of medical necessity and the state's definition. And obviously the state's going to win. So there are cases going on saying, well, you haven't updated your medical necessity standards since 1979. And the research on this condition is profoundly different. So it may happen that you may not satisfy the medical necessity criteria from an insurance company, but that doesn't mean that you don't satisfy them with the state, and the states are much stronger. So moving on to the next slide about external appeals, I would like a reiteration of the patient's functional impairment and the probable consequence if the service is not authorized. So specifically name it. Is it anorexia? Is it self-harm? Is it harm to others, permanent brain damage, failure to meet age-appropriate social norms, any of those? I take a really overt blood on your hands approach, where it's like, you're not allowing me, and I'm not doing the treatment, but you're not allowing the medical team to do the treatment that these experts are recommending in the care of this patient. That's on you. And I review the consequences if they don't authorize a treatment. So for example, I have a friend who works for a major news organization. Is there a possibility that the family could rely on a friend like that and threaten going to the news about this? Could there be a company-wide health insurance shift? I've worked with executives sometimes who have a lot of play with their human resources. And if there's a poor experience with the insurance company relating to an authorization request, can they shift the entire company away from that particular insurance company? I kid you not, I've had it happen more times than I can count. And what about the possibility of legal proceedings? And lastly, if possible, put it on attorney letterhead or give them a letter from attorney and support. Can your practice or organization work with a healthcare attorney and retain them for these kind of situations? Or does a family have an attorney friend that can put this letter on their letterhead? If there is some threat by the provider or the family of legal action, it may cause them to take it a little bit more seriously. It's not necessary. I've certainly done it without any legal support, but I would say it doesn't hurt. So again, you have all of this information in your handout, but I look at support letters from colleagues, an overview of the patient's presentation, the published research about the service, any state or federal laws, the medical necessity criteria coming from the insurance company, a reiteration of the functional impairments and the consequences. And that could include not only a deterioration of the patient's symptoms, but also any legal, social media consequences, things like that. And ideally putting it on an attorney letterhead. And if you can't, you can't. You're not required to be an attorney to file any of these appeals, but it certainly doesn't hurt. So really quickly, I want to talk about some strategies. I mentioned it already, but I think it's really important to get support from other colleagues. So can you ask your colleagues for support letters? Let's pretend you work at a program where there are 8 of you working in the treatment of PANS PANDAS, and you often collaborate. Can you create boilerplate letters where you're taking the patient's name and their date of birth, and then you say, here's the service that's being requested for this patient's symptoms, and here's my expert opinion that it's medically necessary. There's strength in numbers. When you're doing a case shaping call or a peer-to-peer, remember what I said earlier, which is insurance reviewers are required to read all documents that you send over prior to the phone calls. Ask them directly if they've done this. They often haven't. So if they haven't, I want you to document it in the chart that basically if they denied it, that they issued a denial without even appropriately reviewing the medical record, which is really important. We're going to want to see that on subsequent appeals if you go to an external appeal. And also, as I said, there's that script. The insurance company might try to limit how much information you provide. They can't do this. So how I do that is on review calls, I'll ask them to read it back to me. And I'll say, okay, I just provided you, a laundry list of the symptoms and of the treatments that we've tried. I want to make sure you captured all of that information. Can you please read it back to me so that I make sure that it's there? I know that it's your time, and I know that your time is valuable. The work that you all do as providers is invaluable to families like mine. But this extra step might actually be one of the things that helps illustrate to an appealing agency that the insurance company did not do their due diligence. If an insurance company exceeds their own defined timelines, that may mean an automatic reversal of the denial by regulatory bodies. So I want you to document in the case note, whether it's you or it's a nursing lead or it's an administrative department that's requesting authorizations and doing these peer-to-peers. Make sure you're documenting when it was requested and then when it occurred. And if there's too long a timeline there, then it may actually necessitate an automatic overturn of that denial, which is kind of a little loophole that you should probably know about. So I want you to document what you did and when you did it, in case you need to illustrate bad faith on the part of the insurance company. And also, there are a number of states, I forgot to mention this earlier when we were talking about state laws, there are a number of states that have actually enacted legislation that make coverage for PANS, PANDAS, autoimmune encephalitis treatments required with insurance companies. Some of the insurance companies may not have caught wind that that's happened in the states. Another reason why you want to stay up to date on the laws. As we speak, there's one going on in California. My gratitude to the folks who are involved in that. I really appreciate it. For all of you that have taken part in the legislation to get these services mandated, I really appreciate it. Kind of most importantly, I'd say in this presentation is just for you to be prepared. So you need to stay abreast of any updates relating to PANS patients and specific treatments, and keep copies of these relevant laws right within reach while you're on the phone with insurance companies, and make sure that you're quoting them in the appeals. Just absolutely critical. My thing is I always focus on these phone calls on patient safety and quality of life. So when they ask you for 12 symptoms, or maybe 3, let's say you have 12 and they only give you 3 options, I want you to list the 3 most risky ones, because really we have reviewers who are churning through charts and they're capturing a very quick clinical picture of what's going on with a patient. So lead with your strongest foot, so to speak, and make sure to reference clinical studies and look at those medical necessity guidelines. You are an expert in that patient. That's why you're advocating for their care and you're treating them. The reviewer is not. So it may come on you to educate them and say, well, actually, there was a study done looking at the long-term impact of PANS related to plasmapheresis that found blah, 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 blah. It's fine to do that. If you know it off the top of your head, I actually really recommend it because it helps you establish expert status. And also want to point out, the squeaky wheel gets the oil. Don't be afraid to go up the chain of command or ask for a different reviewer. Sometimes we talk to a reviewer and I promise you, as soon as you open your mouth, you know that they're already formulating the denial. Unfortunately, that happens. Document everything in a case note and don't be afraid to push it up the line if you need to. I've seen this happen so severely before that I've actually taken it up to the medical director, which was, excuse me, unusual to me to take it that far, but the reviewer had really developed a reputation for issuing denials without even really reviewing the case. So I was able to talk to the medical director and we got it reassigned to a different MD. So if you have a really bad feeling, it's okay to be the squeaky wheel and ask for oil and ask for a different reviewer. So I know we just covered a lot of information in a short amount of time, but to recap the most important points, how to use all this information to your advantage. Be prepared. Make sure you keep updated copies of your state's medical necessity laws and the insurance company's care criteria right at your desk, on your desktop of your computer. Quote them directly. I really recommend that you follow through on denials. Appeal, appeal, appeal. And if you can't, and let's pretend a patient is so in need and the family said, okay, we have taken loans, we're going to pay for this out of pocket. Make sure the family knows that they can do those external appeals on their own. So they may be able to get that denial overturned and get all of those services reimbursed. And in all notes, make sure that you're illustrating how the patient's functional impairment indicate medical necessity. So answering that why is this treatment necessary right now? Why this particular treatment? Why for this patient? As I see it, all of you are invaluable for the work that you're doing and the help that you're giving to families like mine. And it's really a matter of seeing this through the lens of the insurance company, learning some of these strategies, and using the laws to your advantage to help advocate as efficiently and succinctly as you possibly can. Again, as one PANDAS parent, thank you for all of the work that you're doing. I know that all this administrative stuff isn't a detail that's just on a list of so many details that you're already worried about, but it really does make a difference to getting these authorizations for these patients. And we're grateful when your staff can put in that a little bit of time and strategy to help secure these authorizations. And with that, go forth and advocate. Again, my name is Beth, and now we're going to move into a Q&A section. Thank you so much for your time and attending, and I look forward to hearing from you and hopefully answering some of your questions.
Thank you so much, Beth. I learned so much during that session. Thank you for presenting with us today. I'm going to start answering some of the, asking you some of the questions that we didn't get to during the session. I'm going to start with one from Sarah, who asks how we could construct an argument when the state does provide coverage for IVIG for those on Medicaid. How do we hold commercial insurers accountable to that which the state is then providing?
Thank you. And thank you, Sarah, for this question. I think it's a great one. This has certainly happened before. It's actually happening in another number of states as we speak, where you have mandates for particular treatments coming through Medicaid, but they haven't translated yet to the managed care world. How I view that, if I were talking to, or actually, let's say I'm writing, just for simplicity's sake, let's say that I'm writing an appeal, or even writing just simply the authorization request, I would start by stating that Medicaid law that says in this state, here's what we do, knowing that the insurance company is going to say it and see it and say, great, we're not Medicaid, do it anyway. And then I would say, if a child with Medicaid is able to get this benefit, how can you reasonably deny it? And then from there, in that internal appeal with the insurance company, I would share the specific medical necessity law. So irrespective of what they're doing with Medicaid, I would get that medical necessity law in my state and say, okay, here's the thing. This service is deemed medically necessary by the state of XYZ, wherever you are. And I would state that in my letter. And then I would share, look, even Medicaid is mandating this. And if this is denied, we are absolutely going to file an external appeal. And given that you've shown that you are unwilling, assuming you've already gotten a denial, that you are unwilling to authorize this, we will absolutely take this to the external appeal. And that's where you kind of dig in a little bit and make that threat of, here's what's going to happen if it goes to an external appeal, because they overturn generally the majority of the claims we get. So that's California. But I mean, they really are there for patient advocacy. And it's been my experience having filed appeals in other states. So I should note, while I'm in California, I have managed appeals in other states. One of the other questions was, what do we do if it's out of state? You have to go with the policy state. So even if the patient is in California, but their policy is in New Jersey, let's say, I have to use New Jersey laws in order to be fighting for medical necessity and coverage for that person.
Makes
So
sense.
then I would be looking at the New Jersey laws at the medical necessity definition, and then going through the New Jersey Department that of Insurance or Department of Managed Healthcare, or whoever it is there, in order to manage that. But so going back to this issue, this discrepancy between Medicaid and insurance, again, I would recommend stating to the insurance company, here's a Medicaid law, here's the state law relating to medical necessity, and do you really want to be responsible for a child with Medicaid getting this coverage and this child not? And then say, and if you don't authorize this, I'm totally going to go to an external appeal, which is basically going to take more of your staff power. And it also increases the likelihood that you get on the radar of the watchdog agency and you could potentially get hit with a fine. That's what
I
I
think
would do.
that external review language is so helpful. I think so many folks don't know to take it to that next level. So thank you. That's really helpful.
Yes.
All right,
Absolutely.
Craig. Hi, Craig. Craig has asked, how do the newer PANS laws passing in more states such as Charlie's Law impact these denials?
Thank you for attending, Craig. Great question. So here's my perspective on this. Number one, it's great that we have things like Charlie's Law that are happening. When we're looking at standard of care is not specific to one state or territory. Standard of care is just kind of across the profession. So even though in California, we currently don't have that law and it's pending, in my appeals, I actually quote the other laws by saying, well, look what they're doing over there, and look what they're doing over there, and look what they did over here. Clearly, there's a standard that this needs to be covered, so you can't very well deny it. That's how I do it. And obviously, if there's a denial in a state that already has one of these laws, then that needs to be your immediate comment is, I kind of tried to go with the benefit of the doubt. This is me using honey instead of vinegar, where I'll be like, I think there must have been a mistake. It seems like we forgot about the new legislation that was passed on XYZ date. Would you like to reconsider this denial in light of this law? And if I'm on the phone with somebody that's denying it in a state where there is coverage or there's an oversight like that, I just say that. And it's been my experience that the person is like, I need to go talk to your manager. I'm like, okay, I'll be here. I'm going to go get a drink. So I try to assume that it's just an oversight. Plus, we're way more seasoned in these conditions. Certainly, you all are way more than I am. Well, lived experience. But from the perspective of the insurance company, these people may have no idea what PANDAS is. They truly may not know what any of these laws are, particularly if they're just care advocates and it hasn't gone to the level of a peer-to-peer. And even then, within a peer-to-peer, goodness knows there are plenty of doctors who have no idea what this is. And so that doesn't mean they have an automatic negative perspective or a positive perspective. They truly don't know. So they also may not know that there's recent legislation saying you can't do this. So I would start by reminding them. And then again, if you're in a state where they don't have that law, use those other laws.
All right, wonderful. All right, we've got another question here that I think would be helpful to understand. How do you combat state law that states that a service is not medically necessary if it's considered experimental or investigational?
Great. So that's actually an issue that comes up in California. In order for it to be a qualified service in many states, yes, it can't be considered experimental. That said, there has to be some definition in the state of what experimental means. And generally, experimental means that there aren't peer-reviewed studies backing up the treatment. There may even have a specific requirement to say, this basically has transferred this treatment from experimental to legitimate to standard of care. So in California, it's a mere 2 peer-reviewed studies in order to say, yes, but. So I would present those studies. I always present more than I need, even if the minimum is 2 or it's 4 or wherever I am. But generally, I find that there is some state definition that will tell me what experimental is, and then I can directly kind of deconstruct that in my appeal.
Okay, great. Brittany asked if Minnesota statute has a law in place to not deny any treatments related to PANDAS, but the self-insured health plans don't have to follow this statute, then what's next?
Same thing. So all insurance plans, going back to the question with Craig, all insurance plans are somehow subject to some kind of watchdog agency. So even if it's a self-funded plan, understanding who the watchdog is, understanding what they use to determine whether or not something is medically necessary, getting that language. And for record, if you call the insurance company or a benefits person calls the insurance company and said, who's the reviewing body for denials, they have to by law tell you. So you don't even necessarily have to wait until you get that denial letter. You can call and ask them and they're going to say, oh, it's the Department of Insurance so-and-so division. And then you contact the Department of Insurance so-and-so division and say, can I see your medical necessity criteria to understand how you make determinations about appeals? And then you give that back to them. So again, I would take the other pro PANS treatment resources within the state and put it all into that denial, but really you're going to end, or excuse me, that appeal, but you're really going to use that research that, or the law, I guess, the language is coming from your particular state's reviewing body to make the real appeal and say, this is why you have to cover it. So it's actually, it's okay if there isn't necessarily a law for that particular plan, as long as there's enough research and the symptoms and expert opinion, all of that to back up the recommendation by you as a provider.
Okay, great. I think we have time for about one more question before we close. I do want to note that the post-webinar information is all up in the link. And if you're registered and present here, you'll also receive an email from us with all of your certification information, a copy of the slides, a copy of resources, and as well as a copy of this presentation in case you arrived late. Or if you want to share it with other medical providers. So Beth, I'll give you the last question here, because I think a few of these you've really kind of covered in your answers. Moshe asks, how do I get an approval for an out-of-state consult for a patient with a commercial plan that won't cover out-of-state?
Ooh, that's a very good question. This is one of those times that I'm going to say I don't know, and who I would recommend contacting on the handout. On, I think it's the 7th or 8th page, there are links in there of recommended reading, and I link to an organization that's called the NAIC, which is a National Association of Insurance Commissioners or Commissions, and that is probably your best resource for understanding kind of this umbrella that looks over all of the states, and then getting in touch with the state where you are and potentially the state that this policy is, and talking to both agencies and seeing what their recommendations are. I wish I had better information, but this is one of those times where I'm going to say I would go there and go higher up and see what they say specifically to do.
And that's actually why I chose that question for the last one, Beth, because there are so many great resources that Beth has listed for you on the handout, because you are going to have individual situations where you're trying to figure out how to build that request. And so please use those actively. It can be your really resource guide for many years as you try to think through not just how to handle denials for PANDAS and PANS, but for other kids in your care that may need additional help. With that, Beth, thank you with all of our heart. We so appreciate your help today. This is a huge problem for so many parents and physicians, and we really appreciate your support today.
My pleasure. I hope it's been helpful for you. Thank you all for the work that you're doing, because if it weren't for all of you, then all of us would just be floating around without help. So thank you, and thank you for trying to help advocate in a system that's stacked against us. I really appreciate it.
Genuinely, thank you to all the physicians and nurses and other medical providers that are here today trying to learn more, and to all the parents that are here trying to educate and help their physicians. We appreciate all of you. Thank you for being here, and have a wonderful night.